years. We'll be starting with researching from last 3 years. We'll see how the examination has been coming and where the questions has been setting off. So in EMC examination, from the research, what I found is the clinical handbook is very, very important, where almost 4 to 8 cases are coming directly or indirectly. And the pilot cases from the last 1 year are very important as well. So you can easily find 2 to 3 cases or 1 to 2 cases from the pilot program. Basically, yeah. Now for physical examination, it's also very important. You can see 2 to 3 to 4 cases, and with directly or maybe indirectly or getting physicals. I mean, the history, you can find 1 to 2 cases. So altogether 3 to 5 cases are coming from physical examination. You can also expect 2 to 4 cases from the same months of recall. So very important to follow all those same months recalls, which can from there you can easily get 1 to 2 or 2 to 4 cases. So let's have a research on the examinations that held on 19th of May 2021. Hang on a minute, please. All right. So if you see recall in 19th of May 2021, there are almost 15 or 16 cases. From there, if you see in handbook cases, there are almost 6 or 7 cases come directly from handbook. So handbook is very, very important. Over there, if you see in medicine, the case came as essential hypertension, neck pain with cervical radiculopathy, UTI, shortness of breath with lung cancer, explain chest X-ray, which was a pneumothorax case, explain knee pain, left inferior fossa pain, iron deficiency anemia, which you can in condition 70, 71 directly, GBS, which you can directly find in condition 81 in handbook. OCP counseling is also a handbook case you can find in condition 9. In pediatrics, head injury, child abuse, neck periods, from handbook you can directly get, like in condition 121, you directly get child non-accidental injury, which is mostly talks about in the recall. MSc is also a very common, frequently asked question from psychiatry. You can get that is a indirect question from the handbook. Serotonin syndrome is also a direct question from condition 88. So let's have a look in handbook. If we try to find 88, which is almost similar case from your handbook. So in handbook, it comes as your next patient is 30 years old, bank clerk who is consulting you in the emergency department of general hospital. She is complaining of severe nausea, headache, and jitters. She attended here 2 days ago. Brief notes in emergency department. Patient records state that she has been complaining of back pain, which was diagnosed as muscle pain. The notes also state that she had taken the selective serotonin release inhibitor, SSRI, Prozac, 20 milligram daily for depression for 3 weeks on the advice of a local doctor. Without much improvement, an alternative SSRI, 100 milligram daily, was prescribed when she attended the emergency department. So as you see, these cases are coming from the handbook. So knowing all the cases from handbook is very important. And if you, there's not many cases in the handbook. So please go through all the handbook cases. That will give you a good hold and good base of, and you can easily ease up this examination. Beside this, physical examination also very important. Please read and review all physical examinations. And if you get 5 to 6 cases from handbook, 3 from physical examination, and 1 MSc or MSc, so it's almost 10 cases, easy to pass. It's the same thing happening in 2020 as well, as you say, and also in 2019, as you see, all these times, um, they're direct or indirectly, a lot of cases are coming from handbooks. So read all 121 cases from handbook, and do the physical examinations very, very carefully. So in hand, there are 150 cases. Please try to read them, or try to do very all the related cases. As you know, there are all the key points for the examinations you can find in the handbook. So try to read handbook as much as possible when you do the relative cases. All right. So as this is a longer class, so let's don't waste time and start the cases in GI tract. So our first case is you are working as a RMO, resident medical officer in emergency department. A 40-year-old male presented with chest pain for the last 2 weeks. He also complains of heartburn and indigestion for the last 6 months. An ECG has done, which comes out to be normal. His grandfather had a history of stroke. Dad had recent heart attacks for 3 months back. Your task is to take relevant history, explain the diagnosis and differential diagnosis to the patient, investigation and management. All right, guys, let's take 1 or 2 minutes to read this carefully and find out what could be the differential diagnosis from here. Let's take 1 minute from now on. Yeah, have we read this case? All right, guys, what are you thinking? What could be the differential diagnosis for here?
So it could be good.
It could be good. Why do you think it could be good? What's the
Because
reason?
He's having chest pain for last 2 weeks and the ECG is normal, and there is a complaint of heartburn and indigestion for last 6 months.
Yeah, excellent, very good. So these are the key points, isn't it? So the chest pain is not a new, not an acute condition. It's ongoing for last 2 weeks. ECG is normal. And what's the type of this? Is a heartburn. All righty. What are the is anyone have any other diagnosis in the mind?
It could be other causes like peptic ulcer disease. It can be from cardiac origin also, as the chest pain. So we need to exclude the ischemic heart disease conditions as well.
Yeah, excellent. Anything else?
And then as there are long time history of indigestion and heartburn, we can also consider about the esophageal conditions like esophagitis. That also need to keep in mind. And then few other conditions like peptic ulcer disease and cholecystitis could be other differentials.
Yeah.
So it could be cancer of esophagus or stomach.
Anything else?
Yeah, it could be pancreatitis.
Yeah.
Or trauma.
or trauma. Very good. So you see, we have all the differential diagnosis over here. But if I want you to take one diagnosis for this, which one do you think?
Good.
And what are the positive findings you have been, and what are the positive findings you have been expecting in this case?
It could be good because again with the heartburn and indigestion for last 6 months. Also, as the ECG is normal, we can rule out the cardiac cause.
Good.
Also, there's no weight loss, so we can rule out the cancer or POD. And there is no history of trauma has been given, so trauma can be ruled out.
Excellent. All right. Okay.
And then personal history, we can expect that patient might have some excessive intake of coffee, tea, or even smoking history might be positive. And patient might be in too stress, either in work life, or these things can be positive. We can expect that.
Yeah. Good point. Exactly. Excellent. All right. Is anyone would like to do this case? Okay, first let's review all the what are the red flags could be in this case.
What the doctor mentioned already, the weight loss. Then melena or blood in stool, and then blood in vomit.
Hematomesis, good. Dysphagia, could be. What could be other red flags? So other red flags could be if the patient has been using NSAIDs for a long period of time. That could be on other red flags, isn't it? And the age. Fortunately, age is 40 over here. It's not the patient is not that old. Alrighty. Okay, who would like to do this case with me?
Doctor, may I try if everybody is okay?
Sure. All right, let's do this case.
Okay, thank you.
All right, let me set 7 minutes of time and we'll start doing that.
Okay.
Timer 7 minutes. All right, are you ready?
Yes, dear examiner, I am ready.
Sure, let's do this.
Hello, good evening. I am Manjuri Lahi, one of the GP here today. How may I address you?
Doctor. My name is David.
Hello, Mr. David. Nice to meet you. So, from the case note, I came to know that you are having chest pain for last 2 weeks. So I'm so sorry to hearing that, because it must be stressful for you.
Yes, doctor.
Yeah, but the good thing is that the ECG has been done and the report is normal. So it's some sorts of relieving factor. By the way, I also came to know that you have some heartburn and indigestion for last 6 months as well, isn't it?
Yes, doctor.
So it would be good for me for better understanding if you can describe it more for me in your own words. Would you please do that? So how did it started actually, the problems?
Doctor, it's been for last 2 weeks. I'm feeling like my heart has been just burning. And I'm also having some problems with digesting the foods and always feel like it's full.
Okay, so are you in pain now?
Oh, yes, doctor. Yes, doctor, but it's tolerable.
On a scale of 1 to 10, okay, so how would you like to grade it? Like 10 maximum, 1 minimum?
It's 3 out of 10, doctor.
Okay, may I continue, right? Wait.
Yes, doctor.
So, Mr. David, does the pain go anywhere else from your chest to back or in the left jaw, shoulder, left arm, anywhere?
No, doctor. It doesn't
Okay.
travels anywhere.
Okay. Does it go to? Oh, it doesn't travel. That's good. How would you like to describe the character of the pain? Is it constricting, crushing, burning,
It's kind of
stabbing?
burning pain, doctor. Burning pain,
I,
doctor.
I understand. Do you think there is any associated things with this condition? Like if you lean forward, then you feel little bit comfort, or if you take medication, then it helps. Anything?
No, doctor. It's always been constant over there.
Okay. And do you think any special position or any special activities increases your pain, like anything you have noticed so far?
Not sure, doctor.
Okay. So what about your sleep and appetite? Is that okay?
Doctor, I'm having some difficulty in sleeping as because sometimes I got some reflux while I've been sleeping and get some bitterness in my mouth. So I
Okay.
have not been sleeping properly, or I need to wake up one to twice at night.
Oh, I understand. So some water brash, metallic bitter taste also you sometimes you experienced, right?
Yes, some kind of
Yeah.
bitter taste
Yeah.
and feel like
Okay.
something's coming up.
Some food particles after taking food, do you think it's come through your mouth, through your food pipe, come back,
No,
right?
doctor.
Okay. And
No food particle comes through my mouth.
okay. And by the way, where in throughout the day, do you think you? What about your food habit? Do you have to take too much tea, coffee, or spicy foods while you remain in
Well,
work?
doctor. Well, doctor, you see, like we're in Australia and we're a coffee nation. I take 2 or 3 coffees in a day.
Okay.
Um, it helps my nerves down. Otherwise, yeah, sometimes I have to take some food from the nearest KFC. That's all I do.
Okay. And do you need extra? If you like, what you are saying that you are having some sleeping problem. When you lie flat, do you feel any shortness of breath?
No, doctor, I don't feel any shortness of breath.
Have you noticed your burning chest pain increases after taking fatty foods or something, fatty meal or something like that?
I haven't noticed that, doctor.
Okay. What about your body weight? Is it okay or decreasing significantly for last few months?
I think it's been increasing rather than decreasing.
Okay. And your bowel and poo and waterworks, is that fine or any blood in your stool or any problem noticed?
I haven't noticed any blood in my stool.
Okay. Okay. Understand. So any lumps and bumps anywhere in the body in last few?
No, doctor. No,
No.
doctor.
So, okay. Thank you, Mr. David. Please allow me a few minutes to go to my examiner. Um, mm, so, okay. Thank you, Mr. David. From the by the way, just let me ask one more question. Are you taking any medication like painkiller medication, any for a while, or any other specific medication?
Doctor, I just took some Panadol for this time for um heartburn and chest pain. Nothing else.
Okay, but not regularly, right?
Not really.
And what about your do you, a few personal questions? It's just routine. Let me allow. Do you smoke
Um, no, doctor, don't smoke.
and drink alcohol too much?
Sometimes I do drink some alcohol.
Okay, I understand. And any recreational drugs that I should be aware of?
No,
Any
No.
family history of any medical condition you or your in your family, like diabetes, high pressure, gastric malignancy, gastric cancer, anything in your family history?
Like we don't have any high blood pressure history. No
Okay.
cancer history.
Okay, I understand. Thank you. So, Mr. David,
Okay.
from your history, I
Your
think most
time is
likely you
out.
are. Oh.
All right. Please continue.
Most likely you are having a condition that is called gastroesophageal reflux disease. Are you aware of it?
What is that? Doctor?
Okay,
No,
let
doctor.
me
What is
explain.
that?
Let me explain. Let me draw a picture. This is your stomach where the food particles deposit, and this is the food pipe. The from throat when we swallow something, then it goes to the our lower end. There is you can see there is some constrictions, and there is a valve there. Due to some irritation, like too much coffee, smoking, alcohol, all these things can contribute to irritate this valve. So the food particles cannot go normally inside the stomach. Rather, some food particles irritate there, and it causes irritation, and that's why you experience the burning sensation, burning pain, and other sleeping problem, all these things. Is that okay?
Okay.
So,
yeah.
but it's not an uncommon condition. A lot of people might experience due to this stressful and food habit, all these problems. But to be confirmed, because it could have been other causes like peptic ulcer disease or cholecystitis or any other problems, but like ischemic heart disease. But the good thing is that ECG is normal. However, I need to perform some other investigations like full blood examination, liver function test, and then although you have no significant medical history of weight loss or anything, however, to confirm the diagnosis, I need to perform the upper GI endoscopy. Are you with me, Mr. David?
Yes,
and upper GI endoscopy, and then the UDS test followed by 24 hours pH test. All these things will confirm exclude all other conditions like ulcer, peptic ulcer diseases, and all these things. And for management, first of all, I would like to advise you lifestyle modification. You should take less coffee, less junk foods, less fatty foods, and exercise regularly, and try to adopt a stress-free life, regular proper sleep. You can use a little bit to increase the height, 2 pillows during your sleep. Is that okay? And
yes, doctor.
And then I am going to prescribe some antacid suspension medication for you. It should be taken after taking your meal. If that doesn't work, we might consider the proton pump inhibitor then for a few weeks. And here are some reading materials that will give you more idea. I will catch up you in the next follow-up with the reports. And no worries, it's a curable condition, but you need to cooperate with me. Is that okay with you, Mr. David?
Yes, doctor. Is there anything else you want me to do?
Without need, I think you can avoid taking Panadol too frequently as well, because painkillers in SAID also contribute to these conditions, and you should take more. Lifestyle modification will be key strategy here. Organic food, regular exercise, avoiding those things which I already have mentioned. Thank you.
Okay. All right. What do you think of what we need to be changed in this case? As you see over here, you have been taking history for more than almost 7 minutes. But history taking is one of the tasks. It has to be completed in 3 to 4 minutes, isn't it?
Yes, sir. Yes.
So I understand that you have done very well in history. You have tried to rule out all the possible causes of myocarditis, cardiac failure, pancreatitis, peptic ulcer disease, and cancer drug causes. but that you should be finishing with 3 to 4 minutes at its best, isn't it? Then explain the diagnosis another 1 minute, and investigation and management probably 1 to 2 minutes, 1 minute. This is how you just divide your time. But if you spend more time in history, then you cannot finish the rest of the task, and you'll end up 5-3-3, and unfortunately, that will not give you a pass mark, isn't it? So need to be very calculative when you just see the task, because you have to perform all the tasks very like with similar emphasis. So when you just see the task, please make a plan that how long you will take the history, when you will stop, when you have to stop, and where you have to jump to the next stop, next task. I'm happy that way you have taken the history. You have started with Sicora. But if you would ask some hemodynamic stability, that would have been even better. You have talked all the food association, red flags, pH monitoring, all those stuffs. That was good, but need to be more specific about the time management. That's one of the most important thing you need to do. Is there any other suggestion anyone have? Anything else we have missed in this case? All right, let's read this case together. So the red flags that we have discussed in this case is the weight loss, bleeding, dysphagia, age over 55, any mass, anemia, chronic NSAIDs, upper GI or colorectal cancer, and short history of symptoms. Differential diagnosis, as we discussed, the most as the patient is having burning type of pain, so most likely that diagnosis is gastroesophageal disease. The other causes we need to be ruled out is myocardial ischemia, congestive cardiac failure, pancreatitis, peptic ulcer disease, hepatobiliary disease like cholelithiasis, mesenteric ischemia, cancer like stomach, pancreatic, or esophageal cancer, trauma and perforation, and drugs that might be causing this. The key points that we need to be remembered over here is hemodynamic stability. As the patient comes with chest pain, so we need to think whether the patient is hemodynamic stable or not. When you ask about the hemodynamic stability, what do you normally ask? What are the key things you need to ask in hemodynamic stability? Anyone would like to come?
Temperature, pulse, blood pressure, saturation.
Yeah, temperature, but we have a mnemonics called TPR, BPS, right? Temperature, pulse, respiratory rate, blood pressure, and saturation. Then we go with Sicora. That's Sicora. Just ask about the site of the pain. What's the intensity? What's the quality of the pain? Is it dull pain, sharp pain, stabbing pain? Onset. When does it start? And anything that making the pain better? Anything that making the pain worse? And is it the first time? The food association is very important over here, as it mentioned. That was very good. Basically, any spicy food or any junk food, any excess of tea, coffee, all this, any alcohol consumption, smoking, those all will make this situation worse. Red flags that we have been talked, and pH monitoring. These are the key points we need to. These are the boxes we need to trick in the exam. So it's a very it is a very frequently asking question, and a very frequent presentation in the ED. So in history, we'll be adding in all the stuff with hemodynamic stability, Sicora, that we already have discussed. So if the patient has any pain, we'll be asking about if the patient is allergic to any pain, and we'll offer some pain relief. The quality of the pain, whether it's a dull, sharp, stabbing, burning, or contracting pain, any heaviness, crushing, or throbbing, to rule out all the causes of acute myocardial infarction or other causes of chest pain or abdominal pain. Need to know about the onset, whether it's a chronic or acute case. Any radiation or aggravating and elevating factor, and is it the first time? So it was a gastroesophageal reflex disease. Basically, it's a substernal chest pain. Sometimes it gives with a sore throat as well. Metallic beta test is or water brush. This is how they present. They'll give these words directly. So remember these words: any hoarseness, any chronic cough, wheezing, related relation with food, any aggravating by lying or flat or leaning forward. The positive findings you might find in the exam is an ischemic lunge, weight loss, or weight gain. Basically, if the patient may be a smoker, drink alcohol or excessive coffee, eat a lot, and some spicy or junk food ingestion, these are the main positive findings in this case. If it is a myocardial ischemia, ask about the chest pain, whether it's radiated to jaw or neck. Check the ECG as well. For congestive cardiac failure, ask about the shortness of breath, whether the patient needs an extra pillow or any swelling in the recent swelling in the legs or not. For pancreatitis, ask about the position of the pain, whether it any position that relieves the pain or not. Basically, in pancreatitis, patient might feel relief when the patients lean forward. For esophagitis, ask about any infective symptoms like fever, chills, any increased pain while the patient been pain in swallowing. For tracheitis, ask about the dysphagia. Other thing need to be ruled out whether it's a peptic cause. So in peptic cause, the pain is crowning pain, in heavy pain, deep pain. Remember this one. In burning pain, mostly it comes as cold. Constricting pain, pressure pain is mostly in ischemic pain, and heavy killing pain, that's psychogenic pain. This also you need to be remember what are the type of pain. So if it's a burning pain, cold, it's a constricting pain or pressure radius to anywhere. It could be ischemic cause of the heart. If it's a grounding pain, it's a peptic ulcer disease. If it's a killing pain and the patient is intense pain, think of whether it's a psychogenic pain or it's a drug-seeking behavior. If it's a hepatobiliary cause, this might give itchiness, change in skin, change in pee and poo, and pain associated with fatty food. This is the duodenal ulcer and gastric ulcer, just a quick review. So basically, it's a gastric ulcer that starts 30 minutes, 1 hour after the meal, which is very uncommon. And duodenal ulcer basically starts 2 to 3 after the meal, and you might see some cherry stool due to bleeding. Other causes could be mesenteric ischemia. With mesenteric ischemia, who can tell me what will mesenteric ischemia will give? What are the signs symptoms mesenteric ischemia will give?
Severe pain.
Severe pain, yes, that's right. Anything else?
Blood in stool.
Blood in stool. Very good. Anything else? Yeah, these two are main characteristics of mesenteric ischemia. Might be blood in the stool, severe ischemic, severe pain, and signs of peritoneism could be in physical examination you might find. Good news is mesenteric ischemia case is not coming, but it's a good differential diagnosis. If it's a cancer could be stomach, in pancreas or esophagus. The classical sign of weight loss, lumps and bumps. This is the key questions you ask. But trauma is also very important because perforation in duodenal areas is very common So rule out if there's any trauma that might be cause perforation and that might be causing this kind of pain. Skin infection and drug induced. So these are the all differential diagnosis. You need to ask all these differential diagnosis in a very short time. Please make sure that you are finishing the history and differential diagnosis before 4 minutes. Beside this ruling out the differential diagnosis, we'll also talk about the associate history, like any shortness of breath, chest pain, palpitation, any edema, dizziness, sweating, GI causes like nausea, vomiting, tummy pain, and definitely the cardiovascular causes is very important. Other thing, any indigestion problem, any heartburn, loss of weight, lumps and bumps. These are the associated history. When we have finished taking history and the ruling out all the differential diagnosis, we go with the SADMA, which is smoking history, alcohol history, drug and medication, and any recent admission, any allergic to medication. This history is very important. Then we'll go for any past medical history and family history that the patient has. Once we've done that, in this case, the task, we don't have any task of history PFE, but if there's any PFE, we'll start with general appearance. So what do we ask in general appearance?
Anemia.
Anemia.
Then in general appearance, we should evaluate further jaundice, cyanosis, BMI
good.
of the patient, and
yeah, very nice. So I just remember a mnemonic called pickled. Is anyone have any idea what could be pickle mean?
Spalar, icterus, cyanosis, clubbing.
Yeah.
Colonization, lymphadenopathy. Yeah.
Yeah.
Dehydration.
Yeah, dehydration, edema, and BMI. So if you remember all these things, so you don't you'll not miss any of them. So pallor, cyanosis, clubbing, lymphedema, and edema, dehydration, or BMI. So all of them are very important. Why pallor is important in this case? To rule out?
Anemia or blood loss.
Bleeding.
Or
Also.
yeah. Why icterus is important in this case? To rule out?
Malignancy. Then
chronic
peptic ulcer disease, bleeding peptic ulcer disease.
That's for anemia. We also the pallor, but icterus.
Just to rule out the cause of liver or any obstruction.
Excellent. Yeah. So just with icterus, we rule out hepatic cause. Why C, clubbing?
Cardiac cause.
Cardiac cause. That's very important. And why edema is important?
Heart failure and
exactly,
cardiac
very
causes.
good. All again the cardiac cause. And dehydration? If the patient has any difficulty in swallowing, vomiting, swallowing, all this stuff.
So decrease appetite and
yeah, exactly. And why BMI is important in this case?
Because overweight,
anorexia,
obesity.
Excellent, very good. So look at this in general appearance. We need to ask almost all of them. So better to remember. Remember this mnemonic, and if you need some information from the examiner, try to pick. You don't have to pick all of them. Just be selective and try to understand what are the differential diagnosis you have been trying to out. Be selective and ask the relevant questions. Or if you are not sure, ask all of them to make sure that you're having the right, you're being on the right track. And vitals, I have another mnemonics. There's TPR, BP, BS or BPS. That's what I say. Or TRP, BS. Do you have any idea what are these?
Temperature, respiration, pulse, blood pressure, saturation.
Very good. So why temperature is important over here? Just to rule out all the
infections.
Infection or inflammation or big inflammation. Respiratory rate. Why pulse is important here?
Because tachycardia again indicates infection.
So in this case, do you see any tachycardia by any chance?
No, sir.
No, very good. And blood pressure and oxygen saturation, all these things are very important. This so this two portion looks very very normal, but all of them will give some information regarding any case later on. So for abdominal examination, you have to be thorough because it is as you have been thinking, it's a gastro case. Try to ask relevant all the questions from the abdominal examination, and if the other systems, go through very shortly if you need some information. So for abdominal examination, you go through all the inspection. What are you asking in inspection? What do you guys ask in inspection in abdominal examination?
Abdomen distension, scars.
Distension. So scar, swelling, redness, rash, and
swelling,
distension,
yeah.
right? Any mass?
Yeah.
In palpation, you ask about in superficial and deep palpation whether it's any pain or any mass that you feel. On auscultation, ask about
Bowel
any
sounds.
absent of bowel sound. And what are the special tests you'd like to know?
McBurney's.
What are the special tests? McBurney. Then come up.
Murphy sign.
Go back to the left side. Left lower quadrant. What do you do? Robson sign, right? Okay. So, like, Atlas do these three special tests: McBurney, Murphy, Robson sign. And for respiratory system, how do you ask for respiratory system?
Is the bilateral entry clear, or is there any additional sounds?
Yeah, rear entry equal and bilateral equal.
Yeah.
Added sound, any voice crepitation or something like that. For CBS, what do you ask?
Any murmurs?
Yes, good. So basically in respiratory and CBS, you understand like there will not be a lot of positive things. So you go very quickly in respiratory and CBS, but ask details in abdominal examination if it asks as PEFE. And is diarrhea relevant in this case?
No.
So if it's not relevant, don't put your finger on someone's back passage. It's very uncomfortable. But if it is relevant, like all the liver case and all those stuffs, any bleeding, just you need to do diarrhea, and you need to be selective in diarrhea. You need to be selective in doing diarrhea. For a patient with chest pain, you don't do diarrhea, definitely they'll fail you. And if before doing diarrhea, what is very important? What is
permission?
very important? Permission and
a chaperone.
Present chaperone, right.
Chaperone, very good. Make sure there's a chaperone. You have been asking for a chaperone before doing diarrhea. This is very important to understand all this system. So you have to have a chaperone before you do diarrhea. And what are the office tests we have over here? Maybe ECG, full blood evaluation, or urine dipstick, blood sugar level. So if you need to ask PFE, ask all these questions. Investigation, what the investigation is, do you need?
Like you say, full blood examination, then liver function test, then upper GI endoscopy with pH monitoring.
Yeah, and what else? Do you like to do a lipase test? Yeah, because you're one of the if your diagnosis, if your differential diagnosis, if you have any pancreatitis, do a lipase. Okay. Alrighty, these are the tests you need to do: full blood, serial trope, or a single trope, as because you will be ruling out a cardiac cause. So you do a serial trope, maybe liver function test, lipase, just rule out pancreatitis, per GI endoscopy. If there's any red flag, otherwise you don't have to at this stage. What you can do, you can just refer to GP, and GP can refer to gastroenterologist to do endoscopy. 24-hour PS monitoring, that is all the investigations that you know. For the management, mainly management for this code is behavioral or changes in the food habit. Drink plenty of basically water or fluid. Stop drinking caffeine. Cessation of tobacco, and no eating before 2 to 3 hours before bedtime. Need to elevate the bed almost 30°, and symptomatic treatment for the mild mild symptoms. Basically, for pharma, initially we don't treat with the initially if it's the first time, if it is okay to treat with non-pharmacological, we'll definitely will first of all we'll try to treat not with pharmacological, but if it needs to be treated with pharmacological, we'll go with the pharma innovators. And if proton pump inhibitor doesn't work, if we in the second or third stage, we need to go for a surgical fundoplication. So in hospital setting, what do you do if someone comes with cold? We normally give with some xylocaine jelly and some Myelanta. We just call it a pink lady. That really helps for cold. But this is for the sake of practical management. But for the sake of theoretical, basically first line is to behavioral change. If second line should be pharmacotherapy, that is proton pump inhibitors. Normally we use this 6 to 8 weeks, but taper dose in 4 to 8 weeks if it's requires. And the last line is fundoplication or any surgery. Do you have any question so far? All right, if we don't have questions, just let's read this question and try to understand what's happening over here. Let's take 1 to 2 minutes and tell me what's happening in this case. So John is a 35-year-old, presents to your GP clinic with history of epigastric discomfort for past 12 months. The discomfort is burning in nature, does not radiate up to chest or elsewhere, and lasts from 30 minutes to a few hours. It is temporarily relieved by OTC antacids. The discomfort does not wake him up from sleep, is unrelated to exhaustion, and has inconsistent relationship to eating. John says he has experienced significant emotional stress since losing his job and an executive at Merchant Bank 5 months ago. The pain is worse during stressful days. He has no regular medications and denies NSAIDs use or any family history of GI disease. He is non-smoker and drink approximately 4 standard alcohol drinks per day. Your task is focus history, investigations from the examiner, probable diagnosis and management. What could be the diagnosis in this case?
Peptic ulcer disease due to H. pylori.
Could be. Anything else?
Gastritis.
What are the key points you have been thinking over here? What are the key points you have been thinking here? Why do you think it's a peptic ulcer disease?
Urea breath test positive.
Excellent, very good, good point. And look at the duration.
12 months, more than 12 months. Yeah, long time.
So burning type of nature. So if it's a peptic ulcer disease, what are the where's the closest differential diagnosis for this?
Good.
Good. That's correct. So it all depends on what are the differential diagnoses they will be providing, or how the role player has been will be playing with you. So most likely peptic ulcer disease or GORD could be the answer over here. Let's take the second quiz. Your next patient in GP practice is a 45-year-old Jones complaining of increasing heartburn and indigestion over the last 6 months and has had gastroscopy. Help diagnose this condition and wants a referral for this procedure. Task history, physical examination, diagnosis, and differential diagnosis. On history, you'll find the positive findings of skipping lunch, no weight loss, rather than putting some weight, smoker, drinks alcohol and coffee, eats a lot. What could be the diagnosis over here?
Good.
Good.
Good. What do you think is a good?
Indigestion, heartburn, and the food, coffee,
Very good.
alcohol.
Excellent. Give me 3 key points in this case. Just 3.
Increasing heartburn, indigestion,
Very good.
duration.
Heartburn is the first one. Then
Indigestion,
indigestion. Second
duration.
one, duration.
Mocha,
6
coffee.
months. Very good.
Okay.
Yeah. Excellent. Very good. So this is also a good case. All right. Next one we'll be doing Dr. Vandana. Dr. Vandana, are you there?
Yes, yes, sir. Yeah.
Alrighty. Would you like to read this case? We'll have
Okay.
2 minutes time and let's see how it goes. So you're working as a HMO at ED, a mid-30s old lady presented with severe upper abdominal pain for the last few hours. Vitals are temperature 37, pulse rate 92, blood pressure 100/70, respirated 20, oxygen 94%, white cell count 10,000, lipase 1200, amyl is elevated, DRS liver function test, EUC normal, ECG normal, plain X-ray, sentinel loop. Your task is to take relevant history, explain diagnosis, differential diagnosis, investigation management. So what do you think? What is going on with this patient?
Probably pancreatitis or something.
Why do you think it's the pancreatitis?
Because it's a typical upper abdominal pain, and the amylase and lipase are also increased, and
Excellent,
there is
very good.
sentinel loop.
Yes, very good. So these are the key points. Pancreatitis, what like lipase is the more specific test. Sentinel loop is also another one to very key feature. So what are the differential diagnoses have you been thinking for this patient?
So acute pancreatitis could be there.
Mhm.
Then it could be cholecystitis. Then peptic ulcer disease could be there.
Okay, Dr. Vandana, I understand like you have been trying to rule out all this stuff, but how do you, it's very difficult and it's very easy to miss any cases or any differential diagnosis if you're not with systematic. So once you understand that it's a pancreatitis, put it first one. What could be the second one? When you go to the cholecystitis, Try to say all of the differential from the hepatobiliary. What are the differential? What could be the diagnosis or
Cholelithiasis could be there,
cholecystitis,
cholangitis,
lithiasis, cholangitis? Very good.
cholangitis,
So you're
yeah.
not missing anything. And
And then what else?
go to the liver.
Hepatitis.
Hepatitis. Good. Very good. So once you started with hepatobiliary, try to finish all of them
Finish.
so that you
Okay.
don't miss anything.
Okay.
Then you in pancreas, one could be another could
And
be differential diagnosis.
duodenal and ulcer, sorry, the peptic ulcer disease, especially
Very good.
peptic ulcer disease, gastric and duodenal ulcer, probably.
Very good.
CA
Good job.
pancreas.
CA
And C
pancreas. That's
pancreas
good.
could be there, yeah.
Now, do you understand how you are just ruling out all this differential
Yeah.
diagnosis? So if you finish wherever you were starting, finish all this relevant differential diagnosis so you don't miss anything.
Okay.
So we try to figure out pancreas, hepatobiliary, GI cause. Any other differential diagnosis you want to give? So we get upper GI. Just go a bit down. What could be the other one?
Then mesenteric ischemia, probably early
Yes.
stage.
What are the closest other thing could be close to the liver
To the liver,
and give a lot of pain?
pneumonia, upper lobe pneumonia, sorry, lower lobe pneumonia.
Upper lobe pneumonia, that's correct. And
Sorry,
if
lower
you go
lobe
down,
pneumonia. Then
so lower lobe, not upper lobe, sorry, lower lobe pneumonia, and
lower
go
lobe
down.
pneumonia, cardiac causes, MI could be there, low, inferior MI.
Okay.
Then
Any other differential diagnosis?
there's the aorta also. I don't know if that is relevant or not. Then maybe lower down there's appendix and appendicitis and tubo-ovarian conditions like abscess and PID and all those conditions. But that's lower down, so I don't know.
Yeah, we'll go until the maybe kidney, an aortic stone or something like that. That will be
Yeah.
on enough. We'll not go appendicitis because we understand the temperature 37, so it's not infection basically. It's
Yeah.
mostly coming from something else. Like if it is appendicitis, it will give a lot of nausea, vomiting, and high fever for sure. So we're not thinking of appendicitis over here. All right. And what are the positive findings or key findings you find in the history? You're expecting in the history?
So
Key
key
features.
findings would be patient would be sick looking and in shock. The
Maybe shock, but
maybe
not all
shock,
the
yeah.
time. Yeah.
Then severe
And
pain, which
other
patient will be sitting in the leaning forward position, usually to.
yeah.
And
Very good. All right. And the duration as well.
duration
It will not be for a long period of time because pancreatitis normally comes at is acute, comes in an hour or two because it's a severe abdominal pain, right? Okay. As we have been thinking of investigation, we already have all the investigation. And what is the one thing you need to be, or what are the 2 or 3 things you need to be careful in management?
One, we have to keep the patient nil per oral. So
yeah, that's good. Very good.
And also just like observations, vitals,
Yes.
and all.
Pain management and then
Pain
hydration.
management. Yeah, pain
Yes, very good.
management.
Most important thing
Yes.
is you have to admit this patient. You have to talk to the surgery team and you have to admit this patient, isn't it?
Admit.
This is the first thing. Admit the patient, pain management, IV fluid, nail by mouth. This is the most important thing in this case, isn't it? Are you comfortable to do this case now?
Yes.
All right. Let me set 7 minutes of time, then we'll do that.
Okay. Name of the patient?
Eric. Sorry, Erica.
Erica.
It's a female.
Okay. Yeah.
All right, let's start. Okay.
All right.
Tell me when you're ready.
Okay, sir. Yeah.
All right.
Hello,
let's
Erica.
start.
Yeah. Hello, Erica. I'm one of
Hello,
the
doctor.
medical. I'm one of the medical officers in this ED. How are you today?
Doctor, feeling so much pain in my tummy.
Oh, yes, I'm so sorry to hear that. I'm really sorry. I'll offer you some painkiller. Are you allergic to any kind of painkiller?
No, doctor.
So I'll ask my staff to give you a painkiller now, so that you can be better. And
That'll be great, doctor.
okay, now I'm giving you painkiller. Now you're feeling better? Do you want me to?
Still the same, doctor.
Okay. I'm so sorry. I'll just shift you to the recess cubicle, and I'll hook you up to some to the pulse oximeter just to make sure. So just so that the medication takes effect, I'll just ask my examiners a few questions. Is that all right?
Okay.
Okay. Examiner, I'd just like to know the pulse, respiration, respiratory rate, temperature, BP, oxygen stats of my patient.
Please stick to ask, and vitals are given in the question. Please have a
Oh,
look.
sorry. All right. Thank you. Should I give you some more painkillers now? Okay, I'll give you some more painkillers. Are you feeling better now?
Okay. Yeah.
All right. So I'll just take a quick history, if that's all right.
Okay.
All right. So since how long have you been having this pain?
For 2 hours, doctor.
Oh, I'm sorry to hear that. And where exactly can you show me? Can you point with your finger?
Oh, it's my upper tummy, doctor.
Oh, okay. And what kind of pain is it? Is it like burning? Is it like constricting? Or is it like very deep aching kind of pain?
Oh, it's very sharp pain, doctor.
Sharp pain?
Yeah.
Okay. All right. And is it going anywhere? Like from there, is it going to the back or to the sides anywhere?
Oh, it's going everywhere, doctor, especially in my back.
Or towards the back? I see. And
Yes.
anything which makes it better?
Well, if I lie down, it gets worse, doctor.
Okay, lying makes it worse. All right.
Yes.
And sitting up and leaning forwards, does it make it better?
Oh, yeah, that's why I'm just sitting a bit up, doctor.
Oh, so sorry to hear that. But don't worry, we'll take care of you. And
That will be great.
yeah. And also, I'd like to know if did you have any like any fatty food just before you had the pain?
Fatty food? No, doctor.
Okay, all right. Any fever?
No fever.
So is it the first time that you're having the pain?
Yes, doctor, first time.
Okay, okay. Did you notice like any nausea, any vomiting?
No nausea, no vomiting, doctor.
No fever?
No fever, but having some vomiting, nausea, doctor, no vomiting so far.
Some nausea. Okay, I see. And and are you having any what about your bowels? Are your bowels all right?
What do you mean with
Your
that,
poo,
doctor?
your poo, is it coming all right, or is it different colored?
It's the same, I believe. I had my first one in the morning.
Oh, sorry. How about the urine color? Is it like the pee color? Is it like very dark color? Or is it normal?
It was normal in the morning, doctor.
Okay, I see. Uh, okay, and are you having any cough, any breathlessness, any racing of heart,
No, doctor.
any pain going up to the shoulder or to the arms?
Not really, doctor.
Okay. So the pain, is it continuous or is it coming and going?
It's always there, doctor. Constant
All the
pain.
time. Okay. Right. Have you noticed any loss of weight or appetite, or any lumps or bumps anywhere in the body?
It's just for 2 hours, doctor. Before that, it was all good.
Okay. Okay. Right. Thank you so much for letting me know all this. If you'll excuse me, Examiner, I'd like to know if there is any office test available at the moment, like any ECG.
What do you look? What are you looking?
Or to rule out any MI?
ECG is normal.
No. Okay, thank you. Okay, so now, Erica, from your from the history, it seems that you have a condition called pancreatitis. Have you heard about it?
No, doctor. What is that?
So try not to be alarmed, because actually it is an inflammation of the pancreas, which is a gland right
Doctor,
behind your.
severe pain. Should I not be alarmed?
Pardon me?
I am in intense pain. Should I not be alarmed?
Yes, I think anyone in your situation would be. I'll try to give you some painkiller at this moment. And the condition, so it's pancreatitis. Okay, so it's an inflammation of the pancreas. It's a gland located just behind your tummy. Okay. So
Okay.
these are certain causes which can lead to this. One could be like gallstones, like stones in your gallbladder.
Yep.
Then it could be.
Time is up. Yeah.
Okay. All
Please
right.
carry on. Yeah.
Okay, it could be because of alcohol. Sorry, I didn't ask the past medical history and family history.
Yeah.
It could be because of any trauma, all right, and it could be because of any insect bites or scorpion stings. And mainly these causes. Okay, there could be other causes as well, but those are not as relevant. Like it could be because of swelling in the gallbladder, any stone in the gallbladder, and then swelling in the liver. But those causes seem less likely. What we are going to do at the moment is that I'm going to do I have to ask for the physical examination as well, or?
No, as you see in the task, your task is take relevant history, explain diagnosis and differential diagnosis, investigation and management.
So now, basically, what we do is that we're going to admit you, because this is a condition which can be life-threatening. However, at this stage, since you have come here, it is good that you have come. We're going to admit you, and then we are going to. I'm going to also call the surgical registrar to have a look at you. So we're going to start you on an IV drip and send some blood examinations. So IV drip, and also we are going to ask you not to eat anything by mouth. We're going to give you some painkillers, and also for the investigations, we will be sending a complete blood examination, like full blood examination. Then it's already been done. And some more like a serial troponin, and also we're going to ask for a CT scan, an ultrasound of your tummy, just to see where how bad the problem is, and a chest X-ray and some blood gases, and C-reactive protein, which is just to see how much inflammation is going on. Also, then Yeah, and then we're going to observe you through a few days. And if we see the signs of infection or anything in your abdomen, then we're going to start you on antibiotics. Mostly this will, the pancreatitis will improve. However, there could be some complications, like there could be like a collection of pus around your pancreas. It's called a pancreatic abscess, or a pancreatic cyst can form. Again, these can be taken care of surgically. So anything that you want me to repeat? Did you understand?
Okay.
Okay.
All right. Well done, Dr. Vandana. That's a very good try. Dr. Vandana, tell me where you could improve, where you need to improve.
History, I should have actually been a little quicker. I don't know. And
Okay. The first thing you need to be improved because it's a 7 minute test. If you go beyond that, if whatever you'll say in 7 minutes, that will be count. So your history taking is about almost 6 minutes, and explain the diagnosis and differential diagnosis takes another a minute and a half. So you just missed the third part, management part. So you are not on target. So you need to be very specific. What are the questions you want to ask?
okay.
And need to practice in 7 minutes, 6.5 or 7 minutes. Otherwise, it's going to be very difficult to clear this exam, as because you know you have all the knowledge, you know all the questions. Just need to be specific. What are the key points you would like to ask, and what are the things you need to ask to finish it in 6 minutes or 7 minutes. Okay.
Okay.
All right, you have done pretty well. You have ruled out all the causes of pancreatitis, PUD, pneumonia, lower lobe pneumonia, cholecystitis. As you see, the vitals are given over there. So please, if something given in the stem, have a very careful look. Don't ask them. It's an embarrassing time for the examiner, and just loss of weight, loss of your time. The other thing is investigation. As you see, all the investigation has been done. So don't ask anything about the investigation. Don't repeat. Repetition will kill a lot of your time.
So
Third
the
thing,
office test.
oh, ECG is over there. So what are the office tests you'd like to know now?
It's like urine dipstick, blood glucose, and all.
Urine dipstick, blood glucose. Yeah, have you been thinking? Yeah, you can ask for urine pregnancy test. Any other thing you have been looking for here?
Pregnancy
If it is a
test.
cystitis or pyelonephritis, will not come in 2 hours, isn't it? If it is a PID, it will not come in 2 hours, isn't it? So if you have to be very focused, if you have to take, that's why you said relevant history. It's not a detailed history. You need to have relevant history. I know this is 3 or 4 tasks, and it's not very easy to complete all of them in 7 minutes. So need to be, when there's a relevant history, take the history for 3 minutes or 3.5 minutes. Okay. Or focus history, not take the relevant history. All right. You missed fossil history, family history, and SADMA. These are very important. These are part of
I missed that.
history. Yeah, exactly.
Because I was worrying about the time. So
yeah. So basically, you need to practice a little bit more with time. If you practice, it will be all right, because you know all the basic, all the knowledge you have. Just practice in 6.5 or 7 minutes. It will be all right. All right. Well done. Good job. Anyone have any ideas to input or any comments? Please feel free. Anything that we have missed?
I just have a question. If there is any station like physical examination in this case, then in the physical examination in abdomen, do we need to ask about the 2 specific signs? Apart from, you mentioned that McBurney's, Murphy sign, Robson signs, do you need to rule out that Cullen sign and Gray Turner sign, those things also?
In this case, in this case, this is very important, isn't it?
Yes, yes, that I also actually.
So in this case, that's important, but if you think good, is colon sign is very important or grade level
No,
sign important? Yeah.
no, no.
So as because you see history, diagnosis, differential diagnosis, investigation management, almost 1, 2, 3, 4, 5 of the tasks. So if it's like this, you have to be very focused and you have to be very careful what you're saying, and just you need to make sure that you are ruling out other things and just making the diagnosis and establishing the diagnosis. So be very careful and practice. Try to make it in 7 minutes. Okay, you all have very good knowledge, you all have been ruling out all this stuff, but we have not been maybe we need to practice a bit more to make it in 6 minutes. Okay. All right, let's see together how we'll approach this case.
Sir, I had a question.
Yes, please.
So I wanted to ask, like for this case, after giving pain medication, the patient was still in a lot of pain and we continued taking the
Yes,
history. Can we do
yes.
anything else so that she's more cooperative or, I mean,
All right.
it shows more empathy from our side or just, are we supposed to continue taking the history?
Very good question. It's really a good question. So what do you think in acute pancreatitis, if you give pain relief, will the pain 100% be reduced or eliminate? What do you think?
Probably if we don't give anything less than morphine or pethidine, it shouldn't improve.
It shouldn't improve, but do you think after coming to the hospital in in 30 minutes, the pain will be zero? Will that be happening?
No.
No, there will be some pain in pancreatitis. Definitely, there will be some pain until a certain period of time. And you're the first using this patient, so you have to give some pain relief. And after pain relief, she will still have some pain, and you have to assure that with time it will get better. But it will not be 100% zero in next half an hour, isn't it? And you are the first doctor you have been seeing this patient. You have to go with the pain. Make sure that the pain will improve, but please give me some time and I'll ask you some questions to understand what's happening to help you with the pain. This is how you approach and assure that you are carrying the pain, but you also need to ask some questions to understand what's happening to help you out with the pain.
Okay.
Not every time they will give the pain. This is the one of the question they'll give you a lot of pain because this is a painful situation. Any other question? All right. Okay, let's see how we'll approach. So the differential diagnosis that we have discussed, the similar as pancreatitis, GORD, peptic ulcer disease, CA pancreas, hepatitis, cholecystitis, cholelithiasis, cholangitis, bowel obstruction, ureteric obstruction, lower lobe pneumonia, trauma, or perforation. These are the differential diagnoses we'll be thinking of. This is a very important case, and it's very frequently coming this because the patient will give a lot of pain, and the IMCs, when they'll say pain, they'll be very nervous, and because not knowing this case, because you will get nervous and this will cause you spend a lot of time, and that will make them happy to fail you. So when they're in pain, all right, before starting that, what do you normally give and how much morphine do you give to a patient if it comes with pain? Do you have any idea? How do you start and what do you give? How do you manage the pain?
2.5 milligram IV and then step up.
Very less, very less, 2.5. Start with 5 milligram, 2.5 to 5 milligram. But in pancreas, 2.5 milligram IV. Then if it needs, like repeat that. Okay. Alrighty. And there's one more thing is very important over here, hemodynamic stability. Even though it's been given, blood pressure is given 100/70. Do you want to do anything for this? What do you want to do with this?
We can start on IV drip because in pancreatitis, there's a lot of loss of body fluid. So
Mhm.
probably normal
So do you
saline
like to put a water cannula?
cannula.
Yes, this is very important to whiteboard cannulas because this
Hmm.
patient can anytime go hypotension and shock, isn't it? This is also
Hmm.
very important. Well done with Sicora. We have asked all the question about Sicora site, intensity, quality, onset, radiation. Well, that was pretty good. But did you ask about alcohol association or
No,
any binge drinking?
because towards the end I was looking towards the time management, so I totally forgot everything. I had in mind that
Uh,
I will ask
yes, I
all those
understand that.
things.
Yeah, it happens, and
Uh,
it will more happen in the exam hall.
yeah.
Anyway, just need to hold our nerve. So we like
Yes.
normally IMGs have a lot of issues with holding the nerve, and this is the difference between international medical graduate and local graduates. Local graduates will always be very
Hmm.
calm and quiet, and
Hmm.
if they don't, even if they don't know, they'll make something and come out from there. But over for the IMGs we know, but we have a lot of issues with holding the nerves and we cannot come out.
Hmm.
Anyway, alcohol is very important, especially binge drinking. And ask about the scorpion bite. That's very less, but still, morphine is one of the key points. Admission is key point, and keeping nearby mouth is other key point. As we say, start with the hemodynamic stability and talk about the if we need to put any IV cannulas, white bore IV cannulas or not. Sicora that we have discussed about. So the key over here should be a constant pain. It could be a dull or sharp pain, dull and sharp epigastric pain. Pain will radiate to the back, and lying down will make the pain worse, and which would be the patient would feel a bit better with leaning forward. So these are the key questions you need to ask to understand whether it's a pancreatitis case. From John Muthag, it says severe pain, nausea, vomiting, relative lack of abdominal sign is the triad or is the classical signs for pancreatitis, and the distribution of pain is just epigastric areas. The associated symptoms are nausea, vomiting, as we say, respiratory systems, and rule out all the constitutional symptoms as well. Signs, patients will look pale, weak, sweating, and anxious, tendering the epigastrium areas. Lack of cutting, rigidity and rebound, abdominal distension, tachycardia, and shock. This is why we need to put some whiteboard cannulas for this patient. There could be fever, but not all the time. As we talked about the pancreatitis, for the GORD, any heartburn, water brush, peptic ulcer disease, for frequent use of painkiller. For say pancreas, talk about the loss of weight, weight loss, lumps and bumps, long-term tummy pain, hepatitis, ask about the yellow discoloration of the skin, any dark or pale poo, cholecystitis, ask about the fever, tummy pain, nausea, vomiting, any pain to fatty food or aggravated or by deep inspiration or not all the stops. Colonitis, triad of colonitis like jaundice, fever, and rigor, and right upper quadrant pain. MI, any chest pain, bowel obstruction, excuse me, lower lobe pneumonia for ask about the fever, cough, and shortness of breath, any trauma, perforation. If it is a female, just need to ask a couple of questions like regarding pregnancy, just to rule out all this ectopic pregnancy, all those stuffs. Stigma is very important, especially binge drinking or alcohol. Energy drink, coffee, you can ask about that. So in this case, when you ask about the alcohol consumption, there you'll see this binge drinking or chronic drinking of alcohol you'll find in the examination. Ask about past medical history, family history. Then you describe the patient with 5C approach. We already have described or spoken about 5C approach back there. So most likely you have a condition called acute pancreatitis, which is a infection and inflammation of your pancreas. The cause is your chronic is your brain strain or whatever the cause you find in the history, and the clinical features that you find, like you're having this nausea, vomiting, and severe upper abdominal pain, which is not a very uncommon condition. And if you don't treat or if you don't admit in the hospital, that might cause a life-threatening, that will lead to a life-threatening condition. So there's a mnemonic for pancreatitis is called get smashed. Just have a look on there. The causes of the pancreatitis are gallstone, alcohol, trauma, steroids, mumps, malignancy, autoimmune, scorpion bite, hypercalcemia, ERCP, and drugs. This all causes pancreatitis. Just have a look around. Investigation, as we already have given investigation, most specific is serum lipase level. It will be, which is a more sensitive and specific test for pancreatitis, which will be elevated with amylase might be elevated as well. Serum glucose will be up and calcium will be down. Liver function test may be dearranged. X-ray will show a sentinel lobe, and most important is we might need to do a CT scan just to establish this diagnosis, and ultrasound to detect any cyst or and gallstone that might be causing the obstruction and causing pancreatitis. For the management, we'll be admitting this patient. Definitely, we have to admit this patient. Keep the patient nail by mouth. Give some NG suction, IV fluid, and analgesic, especially morphine. We start with 2.5 to 5 milligram. If patient is allergic to morphine, we can give fentanyl. And ERCP might need if the patient is obstructive. All right, guys, any questions that you have regarding this pancreatitis case? Hopefully you don't have any questions regarding this case because this is very easy. Let's take a 2 or 3 minutes rest. We'll drink some water and come back. Get 2 to 3 minutes rest, move your head around, have a walk, come back, and we'll just finish this class. We'll just continue doing the other cases. 2 to 3 minutes rest, please. Well, guys, it's good to see you haven't left this place yet. Let's start the next case. Was that enough time to change the mind? Are you ready, guys?
Yes.
All right, cool. Who will be doing the next case? Dr. Henny? Dr. Henny, you there? Is Dr. Henny there? All right, if Dr. Henny is not there, Dr. Daniel, are you there?
Yes, hello, Dr. Limon.
Hi, how are you doing?
I'm okay, thank you. I'm okay. I'm just back from work, but I can do. It's okay.
All right, that'll be great. Yeah. We'll discuss together then. Don't worry about that. We'll discuss and we'll do. How's your work, by the way? Doing good?
It's okay. Yeah, it's okay. One of the doctor is on the vacation, and like we are overbooked this week, and yeah.
Yeah, the doctors always have to carry others, all the
Yes.
stuff. So life is never been easy. Anyway, let's read this case together. You're working in a GP practice at 34-year-old male presented with chronic diarrhea for 3 months. Your task: take relevant history, explain the diagnosis and differential diagnosis to the patient, investigation. So we have 3 tasks. Make sure that you're finishing your history in 3 to 4 minutes. 1 minute, 1 to 1.5 minutes diagnosis and different diagnosis, and investigation 1 minute. Okay, don't exceed 5 minutes for history. All right. So what do you think? What are the differential diagnosis will be over here?
Okay, chronic diarrhea for 3 months.
Yeah.
It can be Giardiasis. It can be some.
Okay, let's talk one by one. So it's a Giardiasis.
Okay. Yes.
What are the positive findings you have been thinking of? What are the key features?
It can be some like travel history, of course. It can be also that some like street food, or also it can be.
Okay. What's the key feature? What's the finding feature in Giardiasis? With the stool.
Yeah, stool. It can be that with smelly stool, with I think greenish discharge. Also, it can be what else? Difficult to flush, and also what?
Yeah, that's good. Difficult to flush.
Yeah.
All right. Anyone would like to add in this case? What do you expect in Giardiasis?
Yeah.
What kind of stool do you expect Giardiasis? Anyone would like to add in here?
Also, it can be.
Very good. Watery diarrhea and?
Yeah, watery diarrhea.
Watery bubbly diarrhea.
Very good. Watery bubbly diarrhea and very offensive diarrhea. It will be very smelly.
Yeah.
Okay.
Maybe, yeah.
And what are the other cause could be for chronic diarrhea?
Escherichia coli, travel diarrhea, and amoebiasis.
Very good. E. coli. Yeah.
IBD.
What are the key features in E. coli? What are the key features in E. coli?
Yeah, it can be. It can be first of all like belly, and just like short incubation period. Also, it can be. Yeah, also it can be that sometimes it can be kidney affected, but also it can be nausea, vomiting,
and high fever as well, isn't it?
And high fever, yes, yeah.
Yeah. And what are the causes? What other infection causes might cause this diarrhea?
Amoebiasis.
And what is the key feature of amebiosis?
If you don't mind, this will be bloody diarrhea, if I'm not mistaken.
Yeah, blood.
Yeah, blood. Yeah.
Good. All right. And what are the other causes of diarrhea?
Pseudomembranous colitis, antibiotic induced.
Very good. What's the key features for that?
It can be also it can be blood in the stool. Also, it can be what else? Blood bloating, of course, yeah, but.
And in the history, what is the
and
key
history?
features?
Yeah, and antibiotics, of course.
Very good.
Yeah.
So patients comes with antibiotic having diarrhea. Definitely, it's a pseudomembranous colitis. This case is coming this case. So if we do this case, it's includes all that one as well. Patient comes with antibiotics, having diarrhea. That's a pseudomembranous colitis. So don't fast with other infective substances. What are the other differential diagnoses you have been thinking?
IBD, like
IBD.
Crohn's. Also, it can be, for example, celiac disease, IBS.
Yeah.
Stereotoxicosis, maybe, I don't know, malignancy sometimes, but
hepatitis could be
malabsorption.
Excellent, very good. So we have talked about all the differential diagnosis. What are the investigation you would like to do?
Investigation, it can be first of all like feces. Also investigate the feces. Also we can do blood investigation. Also we can do like LFT. Also proctoscopy, colonoscopy. I mean, in case if it is necessary, and also inflammation marking like ESR, CRP.
Very good. Yeah. So these are the things we need to do in this case. So how do you divide your time management? How do you plan your time management?
Okay, I will try to maybe quickly ask about any present complaints and about is patient comfortable to talk to me, is some emergencies. Then I will ask ask him to point if the pain of point with the finger.
We have 3 tasks over here.
Okay.
We have 3 tasks over here, and give me a plan. How much time you
okay. Yes. Okay, for me it will be 4 minutes for history, 2 minutes for explain diagnosis in differential, and 1 minute for investigation.
Let's see, we can stick with the plan and can execute the plan or not. Let's start this case. Are you ready, or you wanna have 1 minute's time to think?
Yeah.
Ready?
No, it's okay. I'm ready. I'm ready. Yeah. Okay.
If you
Hello.
have 1 minute time to, if you wanted to take 1 minute time to process this, you can have it. It's fine.
No, it's okay. I can continue. I can start. Yeah.
Excellent. Let's start this case.
Okay. Hello, my name is Daniel. I'm one of the GP here. Will be take care about you. Please tell me how can I address yourself.
My name is Eric.
Eric, nice to meet you. Thank you for coming to me for consultation. And I know from the histories that you have some chronic diarrhea for 3 months. Is it correct?
Yes, doctor, it's for 3 months.
I'm very sorry to hear it. Please tell me, Eric, when diarrhea started 3 months ago, it was come and go. It is like constant.
It's always there, doctor. Just 3 to 4 to 5 times per day.
Per day,
and which has
okay.
been constantly from there on, and it's getting worse.
Getting worse. Is it? Do you have? Are you open your bowels like during the day or also during the night? Is it bothering your sleeping? Am I right?
Oh yes, sometimes I have to wake up in the middle of the night, so that affects my sleep sometimes. But mostly it's okay.
Okay, I'm very sorry. Please tell me about the diarrhea. What do you have noticed during the diarrhea? Do you experience any pain or discomfort when you open your bowel?
Not much pain, doctor.
Okay, okay. And what about that in the feces? Have you noticed anything specific? What I mean by this, for example, like blood,
What
any
is
part of
feces,
the
doctor?
feces? I'm sorry, in your poo, have you noticed
Okay.
anything like blood or any some and what's the color and of your feces, of your poo?
No, doctor, I haven't noticed any blood in my poo.
No blood. And what about that smell of your poo? Is any smell offensive or
Oh, doctor, it's just very offensive, offensive smell.
offensive smell? Okay, and
Yeah.
a part of this, have you noticed, or for example, blood on your tissue, on the paper tissue when you?
No, doctor, I haven't noticed any blood
Nothing.
in the tissue paper.
Okay. What about? Please tell me about a part of this diarrhea. Is any constipation?
Not much, no constipation.
Not much. What about your poo? Is it difficult to flush or not?
Yeah, sometimes it's been floating on the pan.
Sometimes difficult. What about a part of this diarrhea? What about nausea, vomiting?
I have nausea, but no vomiting, doc.
No vomiting. Thank you. What about, have you noticed any skin color change?
Oh, no, doctor.
Any change in your color, change in your pee, in your urine?
No.
Okay. Is any chance that you had some fevers, chills, rigors, chest pain,
No, doctor.
shortness of breath,
No.
lumps and bumps and weight loss?
No weight loss, no lumps and bumps.
No. Okay, thank you. And please tell me about, is any recent travel like 3 months back or maybe before?
Yeah, I have been traveling to Thailand, doctor.
Thailand. Okay. And is there any chance that you was drinking like street waters or eating street foods?
Yeah, very rarely, doctor.
Very okay. Thank you. And what about do you smoke, drink?
Yeah, I do smoke.
Smoke, and how many cigarettes per day?
2 to 3 cigarettes per day.
2 to 3 cigarettes. Okay. And what about alcohol?
Very rarely, doctor. So.
Very rare. Any illicit drugs?
No, doctor.
No. What about any allergy reaction to any medication?
No.
Is it any reasons? Is any chance that you was taking antibiotics for any reason recently, like 3 months back?
No, doctor. I haven't been taking any.
And no any
antibiotics.
medication. Oh, no medication. Okay, Eric, if you don't mind, we can talk about smoking and alcohol later, but I know that you're not abusing. Please tell me, allow me a few minutes to talk to my examiner to explain to you the differential diagnosis, and they will move forward about investigation. Is it okay for you, Eric?
Okay.
Okay. Look, Eric, I have examined you and I have asked your questions about condition, and I'm thinking a lot of diagnosis running in my head, but I'm thinking about most likely you have condition. It is called Giardiasis. It is bugs which is came to your bowel from the street food, or it can be from street waters, and that's why it is causing some symptoms which you're having. Unfortunately, it is condition quite common, especially in this development country like Thailand, and it is have a long incubation period. That's why your symptom is prolonged. And also it is less likely amoebiasis because you don't have any blood in your poo. Also it is less likely travel diarrhea because you have diarrhea for 3 months. Also it is less likely IBS, inflammation bowel syndromes, because you don't have constipation. Also, it is less likely Crohn's disease because you don't have also diarrhea and you don't have any ulcers in your mouth. Sorry, I missed this question. Have you noticed any ulcers in your mouth?
No, I don't
Or
have any
anywhere
ulcers.
else? No. Okay, and no joint pain. Yes, am I right?
Yes.
Yeah, thank you. And also, it is less likely that the antibiotic-induced diarrhea, and also it is less likely celiac disease because you haven't noticed any relation to your food. Also, sorry, Eric, what about your diet? Can I ask you about diet? Yeah, sorry. Okay. Investigation is for this one. We need to make a microscopy and culture of your poo. Also, full body examination is RCRP, liver function test, and also I will consider proctoscopy or sigmoidoscopy to confirm or rule out any disease.
Okay. Anything else?
No.
All right. Tell me how we could improve where you have
no, yes, we discuss everything, but of course during the performance you're just trying to cover everything.
Fine.
But
you have done pretty well. We have tried to roll out all the stuff, but just need to make sure what you keep and what you leave, and how you can just finish in 7 minutes. That's the only thing. Yeah, because we already have discussed all the differential diagnosis. We already have discussed all the investigation that we need to do. The questions I need to ask for differential diagnosis. So we know all this over here. Just time management is a crucial part from now on, isn't it?
But please tell me, Dr. Lehman, for example, if for example, I was thinking to ask about hyperthyroidism, but I think how to cover all this differential diagnosis, like 10 or 12.
So make sure if you see this question, you understand this Giardiasis. So what is very, very important not to miss?
Not to miss travel history and also diarrhea, constipation, blood in the stool.
Yeah, all these infective symptoms. Then talk about the thyroid, because these are very, 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 very close. Talk about all the antibiotics, and if it's a celiac disease, inflammatory bowel disease, it's just very with very short question, and you have to make your mind that I'll live this. And if you have to live this, think of which one you want to live. So this is what you need to make your mind before you. That's why I said take 2 minutes time to think. And this in 2 minutes time, you think what I keep and what I leave, what I ask and what I don't ask. So this 2 minutes is very, very important to process your whole question. So use this 2 minutes time very carefully, okay? And always take this 2 minutes time and process in your mind. It's just like you prepare all these things before you cook.
Okay.
All right.
Thank you for advice.
Okay. Any other question? Anyone have any suggestion how we can make it in 7 minutes, and where we need to improve to make it in 7 minutes? Because we know knowledge, we know what you need to do, we know all the investigation, how we can improve. Anyone have any idea, or anyone have any new idea? All right, guys. So if it is Giardiasis, think of all the infective symptoms of, try to rule out Giardiasis, E. coli, amoebiasis. These three are very, very important. Second important thing is whether it's a pseudomembranous colitis or not, because this case is coming. Third thing, you think about thyroid problem. That's also very important, and as it's a chronic one. And fourth one, think of inflammatory bowel disease. So these are the very, very important differential diagnosis. Think of hepatitis, and rest of them you just go with the as you manage the time. So it all depends on which one you will and which one you will remove. It all depends on how is your how do you practice this case. All right. Let's see this case together. So we know it's a Giardiasis case. The red flags are, so these are the points you cannot miss. these are the points you have to trick, and these are the points you'll give the passing marks. So unexpected weight loss you cannot miss. And type of diarrhea, whether it's a persistent or unresolved diarrhea, is very important. Fever is very important to differentiate whether it's a E. coli or Giardiasis or something else. Travel is very, very important, as because you understand that whether it's coming from infective one, hepatitis one, or what is this. Abdominal pain is also important, and family history of any malignancies and Crohn's disease. So you do not want to miss any of the red flags if you want to do this case. So the differential diagnosis over here, as we discussed, Giardiasis, will still give. I have a very good differential diagnosis from John Mutter. So in Giardiasis, the main question you need to ask whether it's a watery, offensive, or bubbly or not. This is important. Or if it's a amoeba, it will give some blood. An irritable bowel disease, you'll give some pellets or ribbon-like stool. All right. Pseudomembrane, this is a case which is coming recently. So this case will cover with this one. Giardiasis is a frequently asking question. Crohn's disease, ulcerative colitis, IBD could be one. This is also coming case. This is also coming in pediatric, basically. So these are the cases mainly coming with this similar stem. So as you see, this is a very frequently coming question. And how do you ask? Because you have spent a lot of time to ask about the about the poo. How do you ask about the poo? What are the question you ask for poo to understand what is going on with the poo? Anyone have any idea? What are the mnemonics we remember?
Is CCVO, color consistency, volume,
Color
and water?
consistency, volume.
Yeah, just remember this CCVO, okay? We don't want to ask a lot of questions to spend a lot of time spend a lot of precious time in the examination. So what do you do? What color is this? Why do we need to know about the color? What do you want to differentiate?
Blood.
You wanna differentiate blood, whether it's MEBSEs or anything else going on, or any malignancies or something like that. What else? What are the things you have been expecting in the, what color have you been expecting? What are other colors?
Pale stool.
Pale.
Pale stool. You have been trying to rule out whether it's a hepatic cause or hepatitis cause. What else? Watery, bubbly. You want to understand whether it's a Giardiasis case or not. Okay. So this is color is very important. Start with the color. What color is this? Is it watery? Sorry, consistency should be watery. Anyway, what color is this? Is it pale? Is it bloody? Is it greenish? What color is this? What do you rule out in content? What do you want to see in content? Sorry, consistency, not content. Sorry, my apology. What do you see in consistency?
Is it watery, solid,
Is it
semi-solid?
watery? Is it hard? Is it soft? Exactly. Very. And volume. Why do we need to know about the volume?
To assess
Is it too
dehydration.
much volume? Yeah.
Yeah, because Giardiasis will give a profuse amount, isn't it? And odor or the smell. Why do you need the smell? Because Giardiasis will give a very foul smelly smelly stool. So just use this mnemonics to understand what's going on with the stool. Then if there's any pain, use Secora. Travel history is very, very important. This is one of the key. All right. Yeah, as we discussed, start with Secora CCVO. The positive finding will be the patient will have diarrhea for 2 to 3 months, 4 to 5 times a day, which floats on water. and overseas traveling to Bali or Thailand or anywhere 3 months earlier. So its incubation period is a bit longer. If the pain in the tummy, there will be some, if the pain in the tummy, ask about the SICORA questions, ask associated symptoms. As we have discussed about Giardiasis, amoebas, and E. coli. So Giardiasis will give with profuse, watery, bubbly diarrhea and foul smelly. Amoebasis will give with bloody diarrhea. E. coli will give recent history of travel, high fever with E. coli. And Pseudomonas colitis will give with antibiotic. Will give a history of antibiotic intake. And patient will present with diarrhea. Inflammatory bowel disease, talk about the crampy abdominal pain, pain in the joint, any rash in the eyes or mouth ulceration. So this is one of the chart from John Muthag. Just have a look, different kinds of consistency of a stool. Differential IBS, celiac disease, lactose intolerance. Think of which one you can keep and which one you need to leave. It all depends on how is your speed and how much you can cover. You don't have to take all the differential diagnosis. It all depends how much you can cover in 7 minutes. So practice and make your mind, this is what I'll keep and this is what I'll leave. This all depends on how much you can do. But malignancy is very important. Thyrotoxic is very important. Hepatitis you cannot miss. You cannot miss all the infective questions. You cannot miss pseudomembranous colitis, inflammatory bowel disease. So these are the things do not miss. Do not miss this differential diagnosis from this case. Ask about SADMA. Ask about smoking, whole drug and medication and allergy. Dr. Daniel probably missed about the past medical history. Please keep in mind, and family history, especially what family history? Which family history is very important over here?
Of IBD.
Yeah. IBD and
IBS,
Celiac disease.
Celiac disease.
celiac, lactose
cancer and celiac.
intolerance.
Yeah. So these are the things you need to clarify from there on. And they describe this as a 5C approach, most likely having a condition called Giardiasis, which is an infection in your gut by a bug. The cause, whatever the cause you get in the history, the clinical features are you're having this profuse, deep, profuse, smelly poo, which is not an uncommon condition. If we if we left you untreated, it might cause life-threatening condition. The investigation that you need to do is 3 sets of stool culture. Might need to do a proctoscopy just to understand if there's any bleeding or anything, any changes going in your back passes. Might need to do a sigmoid colonoscopy plus minus. To understand full blood evaluation just to understand the inflammation. Urine creatine to understand the renal function test. CRP just again to understand the inflammation, and liver function test to understand if there's any tear liver function test due to hepatitis. Equal questions regarding this case. Any question, guys? All right, if we don't have any questions, we'll move forward to the next case. All right, who will be the next one? I have a list. Dr. Shahriar gave me a list. Dr. Henny, is Dr. Henny here?
Yeah.
All right. Would you like to do the next case?
Sure, I'll give it a go.
Oh, that's a good idea. Alrighty, let's see this. Let's have a read this together. Then we'll see what's the differential diagnosis and what we need to do. So before reading these questions, let's see at the top. So we'll have understand what you need to do. So our relevant history. What do you mean by relevant history? How much time you'd like to give in this taking history?
Since there are 4 tasks in this case, I wouldn't
Yeah,
want to
there are
spend
4
much
tasks, so
time.
it'll be a very long case, isn't it?
Yep.
How much time you'd like to give in history?
3 would be optimal, but I don't think like it's possible to finish like before 4 minutes.
3 to 4 minutes, you say?
Mm-hmm. Yeah.
Okay. How much time you'd like to give in PFE?
PFE, I think like 2 minutes.
1 to 2 minutes. Alrighty. What about an investigation? How much time would you like to give investigation?
Okay, so it depends whether the 3rd and 4th tasks are to the examiner or to the patient, because
All right, we have 5 tasks over here, so we need to make your mind before you go to the hall, isn't it?
Yeah.
And this is how they're playing with us. You know, we know things, but they'll not let us say anything, and they'll fail us. So before you go home, you need to make sure how much time you put to pass the exam. So
Yeah.
can you take all the very detailed history in over here?
Detailed? No, maybe like 1 or 2 questions about each differential.
Excellent. Alrighty. And investigation. How much time you'd like to give?
Not more than 1 minute.
1 minute. All right. And diagnosis, differential diagnosis?
Well, 3 to 5, like 1 to 2 minutes.
1 to 2 minutes. 3, 4, 5 to 7. All right. If you execute your plan, then definitely we can pass the exam. All right. So this is our plan, how much time you'll put or how much money we'll put to pass the exam. Let's see, what's the question? You are working in a general practice. A 34-year-old female present with colicky abdominal pain and high fever since last night after eating fried chicken. What do you think?
Well, this is like this looks like a cholecystitis case, but still we shouldn't be tunnel vision. We have to think about our differentials.
Exactly. So you don't have to, you cannot be a tunnel vision person, isn't it? Like, you know, what is it coming, which system is it coming from?
Sorry?
Which system is this pain coming from?
It's probably from the, I don't know. I think we need to like think about all systems, the GI tract, the urinary system, since it's a colicky pain. So.
Okay, so this is where we need to think a little bit of eating a fried chicken. Eating fried chicken, will it give a lot of pain? I mean, will it give a lot of renal pain?
Not usually. That's renal pain is usually like after movement gets worse.
Okay, so what do you think after eating fried chicken, fatty food, which system will give you a lot of pain?
It's probably the GI tract, like the biliary system or the like.
Excellent. So biliary system. So what do you wanna rule out in this case? Where do you wanna put all the money?
Of course, in the like problems related to the gallbladder and the liver.
Excellent. Very good. What are the differentials in gallbladder?
It could be cholecystitis, cholangitis.
Excellent. Very good. And
yeah, this is like for
no, we have one more. One more.
One more in the biliary system.
Yes, please.
I don't know, gallstones is cholecystitis.
Yes, very good. So these are the three things we cannot miss these three things. It's cholecystitis, cholelithiasis, cholangitis. We're covering the bile duct. And what's adjacent to bile duct?
It's like both the pancreas and the stomach duodenum.
And?
Duodenum?
And?
Mm,
Think of close to bile duct.
close to bile duct. The liver?
Yeah, it could be. So we don't want to miss the whole biliary system and liver, pancreas, and urinary symptoms, okay? Like renal stone, because all of them will give a lot of pain. Does it make sense?
Yeah.
And this is the in the box. And what do you want to think out of the box?
Well, depending on the site of the pain, like I might also think if it's the upper area of the abdomen, I might think about like lower lobe pneumonia, or I might think about like.
This is a female.
Oh, if it's female, okay. So if it's lower abdomen, I might think of like pelvic pathologies as well, maybe.
Excellent, very good. So we understand where you wanna put money in the relevant history. So we don't wanna talk about other things like I'm not very happy to say other things like lower lobe pneumonia has a very like very near distant history over here. Okay.
Yeah.
And if it is a PFA, what are the very relevant questions you need to ask?
Well, in PFE, I think in general appearance, jaundice is important. Fever and vital signs.
What do you expect in general appearance? What is specific questions you want to have from your examiner?
I would want to look for, well, in general appearance, whether the patient is in distress is important. Jaundice is important here.
Very good. Jaundice is very important. Very nice. And what else you will be focusing on in the PFE?
In vital signs, I would definitely make sure to ask temperature to rule out cholangitis.
Yep.
And then for the abdomen, like of course Murphy sign, tenderness.
Excellent. Very good. Yeah. How do you differentiate the cholangitis or cholecystitis?
I think there was a triad, the Charcot triad for cholangitis.
Yeah.
So it was fever and I can't remember the jaundice.
Pain, fever, and jaundice, right?
Yeah.
Good job. So cholangitis, you understand with the pain, fever, jaundice. Cholecystitis. What will miss in cholecystitis?
Cholecystitis. There won't be any fever.
Cholecystitis is inflammation.
Oh, okay. So there probably jaundice isn't there then?
Excellent. There'll not be jaundice. Cholelithiasis. What do you expect?
I think then for cholelithiasis is just pain then.
Excellent. Very good. So if we understand these three, basically the most important thing if say cholelithiasis, cholecystitis, or cholangitis, it all is about the playing of the words. And if you make mistake with all this stuff, they'll think it's a knowledge problem, and that will be a very bad mistake. All right. Okay. And for investigation, what do you like to do?
Well, ultrasound.
Yeah.
And
blood
investigations such as ESR, CRP, LFT.
Yeah.
These are the main ones, but I would also like to do the baseline.
If you see all this, that'll be enough to pass. Okay. But let's see how do you execute our plan. Are you happy to continue?
Yeah.
All right, I'll give you 1 to 2 minutes time, just process. Prepare to cook, okay?
Yeah,
process it first, then we'll stop. Let me know when you have time, or like when you're ready.
sure. Okay.
Cool.
I think I can start.
Excellent. Let's start now. 3, 2, 1, go.
Yeah. Hello, my name is Hengam. I'm one of the doctors here, and I'll be looking after you. So I can see from the notes that you're having some pain. Are you okay at the moment? Are you on any pain right now?
Yes, doctor. It's still been a bit pain.
Out of 10, how would you rank the pain? 10 being the worst.
Initially it was 8 to 9. Now it comes down to 4 to 5.
Okay. Are you okay to continue with the consultation?
Okay.
All right. So if it's okay, may I know how you would like me to address you?
My name is Eric.
Eric, pleasure to meet you, Eric. So can you tell me more about your pain, please?
Sorry, my name is Erica. Erica, not Eric. Sorry, it's a
Erica,
female.
okay. Can you tell me more about your pain, Erica?
Well, doctor, it's been there for last 4 to 5 hours. It's my upper tummy, doctor.
It's your upper tummy. Can you point with one finger, please?
Yeah, it's in my just right upper quadrant.
Okay. Is this the first time that you've been experiencing this?
No, I had this pain 3 months back, but it's been all settled down in a couple of hours.
Mm-hmm.
Now this pain has been continuing for last 4 to 5 hours, doctor.
I'm so sorry.
It's
I'll try
ongoing.
my best to help you out. I just need to ask you some more questions. If you could just bear with me, that would be really nice, Erica. So, uh,
Yeah.
what sort of pain is it? Is it a stabbing pain? Is it a cramping pain? What sort of pain? How would you describe this pain?
It's kind of squeezing type pain, doctor.
Mm-hmm. And does the pain go anywhere else, like to your back or to your shoulder tip?
Sometimes it moves to my shoulder tip, doctor.
Mm-hmm. Okay. And is it related to your position? Like when, say, if you bend forward, it gets better, or if you lie down, or related to movement?
Not really. It's always been there, doctor. Its position
Mm-hmm.
hasn't been changing that intensity of my pain.
Mm-hmm. Okay. And has the pain been there all the time, or does it come and go?
It's mostly there for last couple of hours.
Mm-hmm. Have you been taking any pain medication for it?
Yes, nurses have given me some pain relief. I'm not sure what was that.
Okay, sure, no worries. And okay, so recently, have you been having any problems with your bowel motions?
Oh no, it's all been there, just similar.
Okay, and what about your waterworks? Any change in the color of your urine? Or any burning sensation when you pass urine?
No burning sensation.
Mhm.
No change in my color of
Okay.
my urine.
And have you been able to take food down? Have you been feeling sick?
No, I've been feeling some nauseous, but
Mhm.
no vomiting. I haven't been through up.
All right, and I can see that you're having fever too. And I can, did you measure the temperature?
Yes, it was pretty much hot. I was pretty much hot at home. Nurses have measured the temperature as 38.5.
Mhm. Okay, have you noticed any changes in the color of your skin?
Not really.
Any itchiness?
No, I didn't feel any itchiness.
Okay, all right. Can you just please tell me, Erica, do you smoke or drink alcohol?
I do smoke, but not much. And
Okay.
social drinker.
All right. And do you have any health conditions that I should be aware of? Are you on any medication for anything?
No,
Any
doctor.
diabetes?
I've been pretty healthy.
Okay, good, good. Thank you for the history, Erica. If you could just excuse me, I would like to talk with my examiner.
That will be
Okay,
great.
examiner, I would like to assess Erica's general appearance, looking for any pallor, any jaundice, and I would also like to assess her hydration status.
There's no pallor, no
And,
jaundice. Blood pressure is 120/78.
okay, and what about the temperature?
Temperature is 38.4 now.
Okay, and pulse?
Pulse is 88.
Okay, thank you. And I would like to proceed with, I would like to start my exam with a focused abdominal examination. On inspection, I would like to look for any surgical scars, any distension, any visible masses. On palpation, yeah.
There's mild distension, no mass.
I
No
would like
scar.
to, yeah. On palpation, I would like to superficially palpate and look for any tenderness.
The
Any
mild tenderness in the right upper quadrant.
Okay, any rebound tenderness?
No rebound tenderness.
Guarding?
Nope.
Okay, and I would like to perform the Murphy sign.
Okay, Murphy sign is positive.
It's positive, okay. And just to make it complete, like I would like to also do a renal punch, just in case, and look at the renal orifices. And the bowel sounds. I'd like to see whether the bowel sounds are present.
Bowel sounds present.
Okay. To complete my exam, I would like to assess the chest for cardiovascular and respiratory system, looking for any added sounds, and I would like to look for to see whether there's any bedside tests available: urine dipstick, blood sugar level, and ECG.
All right. So cardiovascular system is negative, normal. Respiratory system is normal. What office test have you been looking for?
Blood sugar level and urine dipstick.
Blood sugar level is normal. Urine dipstick is normal.
Okay, thank you. So I think I should explain investigations and diagnosis differentials to Erica, if I'm not mistaken. So,
Yep.
Okay, so back to you, Erica. Sorry for the interruption. Oh, I ran out of time. So, Erica, what I would like to do for you now, most likely you're having an infection going on in your biliary system. Let me get a pen and paper and draw it for you. This is your gallbladder, and this is your biliary duct. What they do is that the juices produced inside your liver accumulate inside this sac, which is called the gallbladder, and you're most likely having it has been infected and swollen and inflamed. It is swollen and inflamed, and this is why you've been experiencing pain. There could be other causes for your condition as well, such as a stone inside your biliary system, inside your liver and gallbladder. There could be problems related to your pancreas, which is a leaf-like gland behind your stomach. It could be related to your it could be an ulcer inside your stomach. So in order to rule my differentials out and confirm my diagnosis, I would like to do an ultrasound. You have to stay here at the hospital and become admitted. I'll also arrange a consultation and I would like to arrange and ask a surgeon to come and have a look at you. And we'll need to do some blood tests, full blood exam, ESR, CRP, urine exam, and liver function test. And please don't worry. We will try to manage this. We will put you on antibiotics, and you, depending on the surgeon's opinion, you might need to undergo surgery. So if you're having any questions, Erica, you know my name, and you can always ask for me, ask the nurses to call me, and I'll be here. Do you have any questions for me?
A couple of questions to you. What's your name? What's your name?
Hengamin.
Hengamin. All right. Where are you now?
Okay, which country I
Yeah.
Or sorry, I didn't get your question.
The reason I've been asking,
Mhm.
I've been trying to understand are you confused or not?
Oh, like,
Because if you see this task,
mhm.
tell me, where did you find management?
Oh my God, I always make this mistake. Oh my God, yeah.
This way
Investigate.
I've been trying to understand whether you're confused or not. Anyway, so
That
look,
happens every
we
time.
do
Oh my
not want to say anything.
God.
We do not
Yeah.
want to say anything that's not in the task. Okay.
Yeah, sure.
And we made a plan that will
Mhm.
finish in 7 minutes. Could you finish that?
Yeah.
So we need to be a bit more selective. Yeah, that was a good presentation. You have tried to rule out all the hepatobiliary causes. Um, just probably missed the past medical history. You didn't ask any question about that, even though I just voluntary told you that I don't have any significant past medical history. Anyway, otherwise, I have asked about SEDMA, like family history and all those stuffs. You have asked about all the hepatobiliary causes, pancreatic causes. Um, um, so it was overall a pretty good history taking, but PF is also pretty good, as because you already have asked about the general appearance, vitals, uh, complete abdominal examination, office test, whatever you, especially the urine dipstick and the normal test. Investigation, so basically ultrasound, liver function test, full blood. These are the tests we need to, and probably a lipase one would be relevant over here, as we just want to rule out pancreatitis. Overall, it was good, but need to be focused on the task. At the end of the task, as because you become very hurry, and you try to finish it up. It's always been tricky situation. You just forgot what to do, but always try to have a look at the task and do according to the task. Okay, don't
Yeah.
give something that will not carry your marks, and you are just spending your time in the examination hall. Okay.
Yeah. Thank you.
Anyone has any suggestion, or what do you think, where you can make it better, where you could improve? Anyway, I'm happy with the presentation. Just need to put a bit more effort on that time management. That will be all right. Okay, guys, let's finish this. We already have discussed all the differential diagnosis. We have discussed about that the investigation that we need. We have discussed about the physical findings that we have to ask from the examiner, and the investigation we need to do. So let's have a look at the differential diagnosis. As we said, we'll be going through the systems. As we have been thinking, it's a hepatobiliary system. We'll finish it up with cholecystitis, lithiasis, cholangitis. Cholecystitis definitely will give with fever and some pain. Cholelithiasis will mostly will not give any fever, just a colicky pain in the right upper quadrant. Cholangitis will definitely give with jaundice, fever, and pain. The other relevant could be pancreatitis, pancreas. All the pathologies in pancreas, hepatic causes, ureteric stones. These are the main causes, and as there's a female, just need to ask a couple of questions regarding to rule out it's ectopic pregnancy or something like that. As the patient comes with pain, start with CCORA questions. If there's any vomiting, ask about go with the CCVO. As we have discussed with cholangitis, jaundice, fever, and chills and rigors. Also some abdominal, definitely some right upper quadrant abdominal pain. If it's a hepatitis, we rule out the hepatitis with discoloration of the skin, the easiness, dark, pale, pear pole. So the The similar we need to rule out other differential diagnosis as we discussed. But if the peptic ulcer disease or pancreatitis with the radiation of the pain, lower lobe pneumonia, if it is any shortness of breath or any cough and cold. If it's a irritated colic or pyelonephritis with any burning or stinging or any fever Schweiger, then we have to go with the SADMA, especially alcohol and acid and illicit drugs is very important. Talk about past medical history, family history. Go and PFE. Most important is the icterus, any skin changes, and if there's a high BMI, because fatty female can easily get this cholecystitis as well. So female fat 40, as you remember, this is one of the high risk for having this cholelithiasis. Vitals are very important to understand if the temperature is up or not. Full abdominal examination is very important. Murphy sign will be positive over here. Other sign will be definitely negative. Respiratory and CVS and pelvic examination very shortly. TR is not very important in this case, obviously, especially ECG and urine diagnostic blood glucose levels very quickly. For the explanation, use the 5C approach, most likely having a condition called cholecystitis, which is an inflammation of your gallbladder. So your liver produces juice, which stores in your gallbladder. Inflammation of our gallbladder is giving you this pain. I've been thinking of other possibilities like colonitis. For this, I don't see any jaundice beside your fever and pain, so it's very unlikely. Thinking of cholelithiasis or a stone in our gallbladder, but as you have fever, it's very unlikely in this case. Think of pancreatitis or inflammation of your pancreas, very unlikely in this case, according to your distribution of the pain. And finish it up, other differential diagnosis that you think relevant. For investigation, basically ultrasound is very specific for having ultrasound. Normally that's a first line, but ultrasound is very specific for gallstone, but not for the cystitis. If it is a HEDA scan, normally we do demonstrate obstructed cystic duct. So these are the main state imaging, and for the diagnosis, there will be dearned liver function test, full blood count will be elevated white cell count. UC might be normal, serum lipase will be normal in this case. So for management, if they ask about the management, admit this patient. If it's a cholecystitis, it's inflammation, infection in the gallbladder, we might need to admit this patient. Most likely, bed rest, MPO, IV fluid, analgesia, antibiotics is required. And surgical review is very important. Cholecystectomy will not be done just when the patient will have cholecystitis. When the cholecystitis will be settled down, then they'll be doing cholecystectomy or elective cholecystectomy. All right. Any questions regarding this case? Oh my gosh, we have spent 10 more minutes. Any question regarding this case? Now, who hasn't? Okay. Dr. Ruby, would you please come to the mic and tell us what we have learned today? Dr. Samira, would you please come to the mic and tell us what we have learned today and what is our outcome today? Yes.
Doctor, I am joining late because
Okay.
I am at work. I can listen only to the lecture that is being done after I joined. I couldn't join early because I'm at work, doctor. Sorry.
It's okay. It's okay. from the last two cases, what do you think? Where we have been, where we need to work everyone, where we have been having trouble, when we have been doing these cases. What do you think?
Time management.
Yes, very good. That's very important point. Or today we have been lacking with this time management. So you have to work very, very hard with this time management. Someone come and tell us how we can manage this time management. Dr. Samira, can you tell us how we can manage this time? How we can just improve with this time management?
Only by practice.
Excellent, very good. That's the most important thing. Only by practice, and you have to make your mind. This is the thing I'll keep in the differential diagnosis, and this is the thing I'll just leave. So this is very important. Okay, so this is our biggest learning. We are lagging behind with the time because we haven't made our mind which one will take or which differential diagnosis is relevant and which is not. And at the last, if you don't have time to describe all the differential diagnosis, just tell the differential diagnosis. So in this case, as you see, in the last one, there was a task of differential diagnosis, right? So we don't have time for differential diagnosis to describe. If you don't have time to describe the differential diagnosis, name all this differential diagnosis that you have in your mind. You don't have to spend time for that. That's in 10 seconds, tell at least 5 to 6 differential diagnoses. Okay, so the teacher will have enough opportunity to give you some good marks in your differential diagnosis. Otherwise, they won't have any opportunity to help you out in the examination. All right, guys, do you have any questions regarding today's lecture or today's class? Any suggestion, any quick question?
Dr. Limon, is there a minimum number of differential diagnoses that we need to explain or exclude?
So I always will encourage you to give that as many differential diagnoses as you can, because but should be relevant, should not be irrelevant differential diagnosis. So give relevant differential diagnosis as many as you can, but at least 5. That would be a good idea. Any other question?
Dr. Limon, I just wanted to ask a general question.
Yes, please.
In the beginning, you said we should practice recall questions. What do you suggest? How many months back should we go?
All right, that's a very good question. You don't have to, like, if you do one year's questions, that will be more than enough. Keep in mind that most of the time there are 1 to 2 or 2 to 3 questions repeat from the same month's recall. So doing this way, if you sit an exam at the end of June, just make sure that you have been doing all the questions, including the pilot questions, very carefully from June 1 to June 30. So you can expect 1 to 2 to 3 cases common in your exam.
Okay, thank you.
Cool. Any other question? Tell us, guys, where we need to focus very, 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 very or very, very nice. And where you have to work very hard. Which book we need to follow? Which book do we need to follow to pass this exam?
Handbook.
Handbook. Look at here. In 19th of May, there's almost 7-9 cases directly or indirectly came from handbook. So there are 150 cases, not even 150 cases, maybe 130 or something cases. Try to read Whenever you do one cases from anywhere, try to read relevant cases from handbook. You have all the key points over there, all the critical errors over there. So if you want to pass this case, if you want to make sure that all the key points you wanna add in your case, read handbook as much as possible. Even if you have all, and if you the handbook has the physical examination as well, you know, so you understand what you need to read and what you need to leave. So read the handbook as much as possible. This is very, very important. Or at least try to do handbook cases with your colleagues. If you don't read, just get the cases and do with your partner. This is very important. Know all the cases from handbook and try to read all the key points from there on. Any other question, guys? We have passed 18 minutes, so I think it will be a good idea to finish the class today. I'll see you next Friday. Have a good day, guys.
Dr. Lemon.
Thank you so much. Have a good night.